Hi, good afternoon, and thank you for joining PQA for today's Quality Forum webinar. My name is Richard Schmitz. I am PQA's Senior Director of Communications and moderator for today's discussion on the Swiss Army knife of pharmacy informatics, the Pharmacist Electronic Care Plan. As you hear, it isn't a unicorn, it is being used now. I want to begin by thanking PerformRx for sponsoring today's webinar through an unrestricted educational grant. PerformRx is a pharmacy benefits manager dedicated to clinical culture, boutique services, and holistic solutions. Thank you to John Butts and the entire PerformRx team for supporting PQA. Just a couple of quick deadlines to make sure you're aware of. Tomorrow is the deadline for submitting nominations for the Community Pharmacy and Innovation Quality Awards presented by PQA with support from the Community Pharmacy Foundation. These awards honor innovative and pioneering individuals in community pharmacy practices. Nomination instructions are on the awards page of the PQA website. So that deadline is tomorrow at midnight, effectively, Eastern Time. And then Monday is the deadline to submit poster abstracts for the PQA annual meeting poster session. The full call for abstracts and the submissions form is on the annual meeting page of our website. I want to quickly remind everyone of three items. Please submit your questions for today's speakers using the questions feature located on the webinar control panel. At the end of today's presentations, we'll cover as many questions as time permits. This forum is being recorded. A copy of the presentation, slides, and recording will be available through the member portal of PQA's website next week. And we have a brief survey for you at the end of today's webinar. We're particularly interested in your ideas for future webinars. So I would now like to introduce today's webinar presenters. Troy Trickstead is Executive Director of CPESN USA, a group of clinically integrated networks of pharmacies. He is also Vice President of Pharmacy Programs for Community Care of North Carolina. A long-engaged PQA member and current PQA board member, Troy is our chief presenter today and will explain the Pharmacist eCarePlan, its value, and current status. And Troy is joined today by Shelley Spira. She is Executive Director of the Pharmacy HIT Collaborative, an organization of pharmacy associations and associate members focused on advocating for the use of health IT to better enable pharmacists to optimize person-centered care. Shelley is an expert on the Pharmacist eCarePlan as well and will provide commentary and help answer your questions. So I will now turn things over to Troy to introduce himself and walk us through the presentation.
Thanks, everybody, for having me. Thanks to PQA for the invitation. I have a particular passion about this piece of work. I think it's really important for all of us, not only in the pharmacy sector, but healthcare generally, and mom and dad and sick cousins and everybody else who takes meds. If we're going to optimize medications, we need to figure out how to make this data liquid and be able to use it to its best abilities. I do want to thank, as Richard did, PerformRx and John Butts. Thanks for sponsoring this webinar and for PQA for posting it. We are going to spend the first 40 minutes going through these 5 topics. We're going to do our level best to leave the last 20 minutes for questions and answers because no doubt it will, hopefully, if we do our job, stimulate lots of questions and feedback. So starting off with the basics, what is the Pharmacist Electronic Care Plan? Well, it's an interoperable standard. So we've all heard the phrase apples and oranges, and the whole idea there is to say an apple is different from an orange, but they're both fruit. And the whole idea here is that just like in banking where financial transactions are universal, if you're going to have multiple different types of systems and different types of settings of care and even different types of practitioners, working together in a meaningful way, which is an almost absolute requirement with medications because they're so ubiquitous, you really need standards. And so you can have people speaking different languages, literally. So if the watermelon's speaking Spanish and the plum's speaking French and the orange speaking German and the grapes are speaking English, et cetera, they could say the same thing, I need help, but not understand each other at all. So again, they're saying the same thing, but using a different language. The key to interoperability is the ubiquity. So it's widely known and used so as to reduce this ambiguity. Critical concept. so that if I'm speaking French, it gets translated to a universal language, and then that universal language can either be read that way or it can be translated into Spanish, for instance, if that's the orange. It's that intermediary agreed to, here's how we're going to structure and use data, and the fields we're agreeing that are musts, and the fields we're agreeing that are optional, and so on and so forth. Oftentimes implementation guides are multiple hundreds of pages long for standards, and that usually turns people off and turns their minds off, but it's really, really important that you're extremely precise. Embedded within those 100 pages are loads and loads of value. So using the example of an NDC, I can have an NDC in Pharmacy System A. I can have NDC in the switch. I can have NDC at the PBM. I can have an NDC wherever it is. It's going to be translated into that NCPDP transaction. So we do about 4 billion prescription fill transactions a year. And what's really neat about it, it's almost faster than a credit card. So when I'm out and practicing, you send that claim, it comes right back. That's not possible without interoperability. The speed with which it happens in pharmacy is pretty remarkable compared to the rest of the healthcare system. But what's happening, of course, is that NDC in my system is put in a different place. It might be represented with dashes and leading zeros where I'm at. It doesn't really matter because when I send it, we all agree to the same way that it's being sent. And then it might get translated to a different place for a different use in a different system. That's the essence of interoperability. So the history of this, it was 2013 that HL7, which is the International Standards Group, and NCPDP, National Council for Prescription Drug Plans, that we're very familiar with, started working on drafting an HL7 version of the Pharmacist Care Plan. And for those of you that are unfamiliar with those groups, NCPDP, think of it as standards that created the claims transmission standard as well as the script standard, electronic prescribing standard. So now we do billions now prescriptions electronically. And again, everybody agrees to the same way that that's going to be sent across the internet. What fields go where? It's NDCs in field 21, and it's this type of format, and it comes through this way. HL7, think of them as the standards for everybody else, not pharmacy in many ways. And so bridging between HL7 and NCPD becomes important. It's going to be really important going forward in time because, as you can tell from mergers, acquisitions, vertical integrations, the world of pharmacy and everybody else's world, we're not going to be an isolated entity anymore. We're going to be in their world, and they're going to be in our world. Home health is going to be in our world. We're going to be in home health. We're going to be in primary care. Primary care is going to be in ours. So those traditional lines are starting to break down. And what's neat about this is it's one of those standards that transcends the traditional silos. Another important milestone in my mind was the Snomed Ct. So in 2016, Snomed Ct gets added. What is Snomed? Systemized nomenclature. And these are clinical terms. And so systemized nomenclature of medical and the CT part. So we needed those, particularly for pharmacists, to say, what is the specific things that we're doing? And having those in there were not only important for us to sort out what we're doing and for program evaluation people, but also for payers to look at it and say, well, if I'm paying for something, I need to know with a little bit better granularity what it is I'm paying for. We'll talk about that in a little bit. If you go forward even farther in the history, June of 2017 was a real seminal moment. That was the first care plan that was actually sent across the internet using the standard and the transaction to Community Care of North Carolina, which is a network of primary care physicians in North Carolina as part of the CMMI, CMS, HCIA Round 2 project, which was the Innovations and Payment Reform project. Where are we at today? Well, it is being used. Lantana is an entity that's been working with HL7, working with NCPDP, working with the Pharmacy Health Collaborative, and it's going to standard for trial use balloting in May. So it's been through a bunch of ballots. If you live and breathe in that world, you know there's a whole big, long process this all goes through because, of course, everybody has to agree for it to work. The standard for trial use is really a really important benchmark. The CCD that's there that governs literally billions and billions and billions of dollars of meaningful use and rewards on the physician and health system side is at that standard for trial use level. So this would put it on par with what essentially becomes ubiquitous on the medical side. So it's come a long ways. I think one of the things that was really important, and I wanted to add this editorial commentary, is that standards are what they are. They're mostly in the abstract to most folks. most folks that aren't visionaries and can kind of see the value and kind of see into the detail and say, wow, if we do this, here's all the things that can come from it. But it needs a testing ground. It needs a laboratory. And that first laboratory, kudos to the Office of ONC, Office of the National Coordinator for HIT, coordinating with CMMI, coordinating with the Pharmacy Health IT Collaborative, and then using that CMMI grant as a laboratory for, hey, we're actually going to take this and actually pass proof of concept, but actually implement it for payment, for quality assurance, and care coordination. And I'll talk about that in a little bit. So that was a really important moment in time as well. Why the care planning? And we'll talk about that, but the contents of it. The rest of the world uses care plans. I don't care if you're in primary care, care management, home health, transitions of care. There's care planning going on, and that needs to come to our shores in pharmacy world. And health concerns, interventions, goals, health status, outcomes, laboratory results, vitals. Makes a lot of sense, right? Just like when you go to the doctor, that's essentially what's put together. Here's what our plan of care is, and off we go. So what does that look like in pharmacy world? Well, health concerns, and you're going to document medication therapy problems. Interventions, more extensive medication history, fill history can be added, more the Snomed Ct codes associated with, that were passed associated with pharmacy activity and pharmacist activity. Goals, well, clearly in pharmacy there's goals of therapy. Health status, emphasis on sections related to medications, laboratory results, and vitals. I'm super, super excited about laboratory results being part of the med use and result and care planning process. That's been missing. And then we decided to add a section which I thought was really, really important a couple years ago. And when Shelley and I talked, and we talked about this, that we really need to add a payer section. We want to create a unique standard that isn't only for coordination of care, but also can be used for interacting with payers, so that there's a section there that you can transact and interact with payers. Payers are becoming providers. Providers are becoming payers. All that whole world is blurring, and meanwhile, payment reform comes along. And payment reform is about accountability, producing outcomes. Well, really, all these data streams need to kind of come together. We can't have a claims stream separate from a clinical stream, separate from a patient-reported outcome stream to be successful. But the idea here was just taking what already exists on the rest of the world side on care planning, which is important for pharmacy, and then tweaking that to make sure that it fits what we need with the pharmacists. So who can use this thing? Well, pharmacy management systems are using it now. Care management systems, interestingly, jumped in on the project. They were the easiest. They tested out the easiest because their systems are designed for care management. Devices, apps, and AI products. Remember, these standards transactions can move at the speed of light, literally on fiber optics. And so the Internet of Things and other types of ways. There's rich information here. Electronic medical records. There's 2 that have expressed interest, working with Shelley right now on bridging that divide. Quality measurement organizations like PQA, of course, and then MTM systems. So broad use, because most everybody's involved in medications, but at the core of it, what is really the value? Some of it's hopefully been obvious in that first section, but let's really dive down into the essence of it. One of the things we learned in our when I was working managing pharmacy programs for Community Care of North Carolina, so that's 2,500 primary care practices, about 1,200 different folks with about 600 traditional care managers roaming the state, a network of over 200 pharmacies, and really a population health management infrastructure with boots on the ground everywhere and lots of different settings of care. And what we thought was, we'll just incorporate the community pharmacies. And in that experience, and I think even when I'm away from CCNC and I'm in practice, it's crystal clear that it is impossible to have a practice, have a meaningful practice, have a meaningful workflow, unless you can manage your panel of patients in the workflow that's going to work in the environment that you're in. So that was the CMMI experience. We had a mutiny on our hands, which I'll describe in a little bit, about a year into the project. But that's our practice experience, too. So I spent a lot of time over the last 20 years working with practices on patient-centered medical home. Same concept is, if it's not within workflow, that encounter-based workflow, and I can't run a report and sort of weave it into that work and bring people into the office based on a report, but have my panel of patients that I'm designing the workflow that meets my environment with my types of providers, it's just really, really difficult. I can't have 6 different subsets of patients with 6 different subsets of workflows and then bill differently, and it's just impossible to do that. this was our experience when we first started the CMMI project. We said, well, there's 4,500 different users of the pharmacy home. It's got discharge lists. It's got fill history in there, complete fill history from the Medicaid program. It's got lab results, discharge notes. We do about 40,000 home visits every year with the care managers, rich history there. When we started working with the community pharmacies, we thought, well, we'll just bring them into this environment. This should be heaven because all this rich information you can read right in. It's basically like a statewide care management EMR, and you'll be on the team then. And of course, about a year into the project, the lead, I would say, voice amongst the pharmacies came to me and said, Troy, you've got a mutiny on your hands. There's no way they can do this unless we take a different direction. And that's when I called Shelley at the Pharmacy HIT Collaborative and said, okay, Shelley, you've been bugging me about this for 10 years. We're ready to be a lab. The time is now, and it's supple. And it's a sea change from making everybody come to you versus saying, well, everybody can use their own system because that's what works best for them, but we're going to have a universal way of communicating. And that's when we really basically said, you use whatever system you want, pharmacies, you use whatever system you want, care managers, you use whatever system you want, primary care docs, but we're going to make sure that everybody's speaking the same language when it comes to care planning and medication use. Why is this so valuable for the rank and file interventionist, practitioner, pharmacist out there? It's universally applicable. This is an open standard, and it can apply. My belief it applies beyond pharmacists, by the way. But if you're in a pharmacy, I can pick any system I want. If I'm in a clinic, I can pick any system I want. If I'm in a call center, I can use any system I want. There's three basic types of systems, and we learned a lot about this when e-prescribing came to pass on the medical side about, standalone versus native, bolted on, et cetera. But you can have a system. So if I'm in a pharmacy, I'm a pharmacy management system. I'm just going to start writing code and embed that user interface, that care planning user interface, that intervention user interface right into that pharmacy management system. If I'm an EMR, I can build that e-prescribing module right into Epic if I'm Epic, for instance. I can do a bolted-on system. A good example of this on the medical side was Dr. First. I think the third most popular EMR out there right now is still Meditech. Dr. First is still the e-prescribing module. You may or may not even know that or realize it, or it's gotten to a point of full integration where they might be separate systems, but they're really bolted on and they're integrated, fully integrated with each other. And then you've got separate standalone systems. So I can have my EMR, my pharmacy management system, and then I can also have my clinical documentation system. I can assure you there is no wrong door here. I've seen between specialty, community pharmacy, long-term care versus community pharmacy, sometimes in the same building, specialty call center. It really, really depends on your circumstance, the type of system. And then, of course, then you get into the actual version of what types of software and who. But these three general ways of picking from a system are possible because of interoperability. So I can be a pharmacist in a practice and use one of the CDSs, the clinical documentation systems that's out there right now. I could work with Epic and create a form as long as I'm transacting with an Epic and able to transact out the electronic care planner in. I can do that right within my system. So again, standards allow this sort of thing so that you can be a pharmacist or practitioner of any type in any setting of care and have a lot more choice and flexibility that meets your particular needs, and everybody's got different needs. From a PQA perspective and from a old hat health services researcher, myself background, health economics background, the multiple data types consistent data gets people like me really, really excited as well. What's interesting about this particular standard and its payload of information is that it has different types of information. So I could have an administrative claim, for instance, out there using the PCMH example where, okay, I need to make sure that somebody got a test. And so for different measures out there, HEDIS measures, there's different claims-based measurements. Certainly PDC is a good example of one of those within our pharmacy world. I'm using an administrative claim, and percentage of patients with hemoglobin A1C may be the measure. It's the claim is the type, and the result is the test was administered. So the entity paying for the test knows that the test was administered. They don't know what the result is. You could have a clinical type of data that says, you know what, we're going to actually hold you accountable for care. We're going to make this part of our CPC Plus or our ACO measures or whatever it might be. And we actually want to know and pay you for percentage of patients with hemoglobin A1C less than 7. Okay, that's a laboratory clinical result, and the actual result is 8.5. We don't know how much it was paid for, what payer it went to, but we know the result was 8.5. Then you've got the type of patient-reported, or sometimes folks will call this user-imputed. Measure could be number of patients with a goal. The patient reported, and the result is this patient said that their goal was to check blood sugar daily. I will tell you the hottest data sources right now out there are that third category. Social determinants, behavioral, what's motivating the patient, what's going on with the patient. What's really neat about this particular standard is that it has all of these types of data included. So it is the Swiss Army knife, and kudos to PQA for coming up with that concept. I didn't do that. 3 general areas it can be used, and we've used these at CCNC and CPSN. We think we're very excited about it, and it works quite elegantly once the vendors are able to transact it, and then it's work with the users. We find that on the patient-centered medical home side too, and the medical side is the data is only good as what comes through. But we're all going through practice transformation right now, and all the software vendors are going through their transformations, and so we'll get there. But the stuff coming through is pretty interesting, fascinating, and valuable. So again, we can use this for payment because it's got the Snomed Ct, and there's a payer sheet actually in the standard itself. Obviously used for care coordination. That's what most people think when they think of HL7, when they think of HIE or care coordination is, I need to tell somebody else, here's the med list. I need to tell somebody else, here's what the lab result is. I need to tell somebody else, here's what the drug therapy problems are. And so, obviously that makes a lot of sense for care coordination. Well, quality assurance is a big one as well, right? So if you have SNOMED level interventions, if you've got rich information about the meds, their goals, the labs, etc., you've got a much better pantry to cook a meal with. And that's the example I like to use when we talk about data scientists. There's a lot of data scientists that go to that pantry every day, particularly with administrative claims, and they're like, okay, we're supposed to do payment reform, we're supposed to do outcomes-based reimbursement, and I'm staring at claims. And, we've been flogging this data for 30, 40 years. And so for payment, great, you did this Snomed Ct code, here's the payment. Oh, by the way, here's the lab result, here's what the patient goals are, and here's who the referral came from, and here's the when we're going to schedule the next visit, and so on and so forth. So if we drill down on this, what this looks like, there's examples on the website that we've put up that go through various use cases and sort of bring to life what the standard looks like behind those use cases. So I encourage you to look at these on the website. But the case flow is just like a note, right? So just like an H&P in a physician's office, it's this type of patient, et cetera, but yet the data is structured. It's really important that it's not just a free-form note. That data is structured. And that's really key to interoperability. And it's tied to value sets and pick lists. We're very familiar with this in pharmacy world. You can imagine what things would look like if I just typed in metoprolol and I didn't pick that from a pick list. Not only is that dangerous, but you're not able to communicate in an unambiguous way. And there's a lot of Six Sigma reasons why you want pick lists. Why is that so important? Because we have to have an agreed to set of pick lists. You can either adopt those within your system if you're software, or you can map those. But in order to send all these electronic prescriptions across the transom out to the pharmacies, of course you have to have these pick lists that are universally understood. So that's the unified medical language, UMLS, SNOMED, et cetera, all are embedded within this, and it fits pharmacy world real well. So if you look at the actual case here, Dr. Smith referred Susie, who's a 67-year-old white female, to local pharmacy's diabetes management program. If you read all the way through this, it would look like if you went to pharmacy school or even medical school or nursing school, a note that you would put together in therapeutics class. Okay, here's the result, here's what's going on, here's where it came from. Here's the patient goals: check blood sugar daily, set a quit date, schedule a physician's appointment. Awesome. Referral from by doctor. What's really cool about this, there's actually a numeric code that's associated with that. So if I pick that on my pick list, now it's attached to this note. Oh, okay, this is a very universally understood code that says referred by doctor. Really, really important, by the way, for programs like CCM and emerging programs within CMS that require this care coordination in order for payment. Then I've got drug therapy problems. Okay, I've got these 2 drug therapy problems. Well, medication dose too low. Well, that might be what's represented, but what matters again is granular numbers. These are the actual numbers that are associated with those, and they're in pick lists, and those value sets represent. Now, you might be able to modify those in a software system depending on where you're at and what the audience is, but everybody sends a 448152200. Really important. What's the encounter, reason, and type? So I did a diabetes medication review. The example I like to use is the game Clue here. This ages me a little bit, but I encourage anybody under the age of, not in their 40s, to Google search Clue the game. Fascinating, interesting game. But the idea here is you can't just say, and this is what we do with MTM, this is what we do with CMM. We try to create words around something. We say, well, we don't do CCM, so then, or CMM, Comprehensive Med Management, because we want to define it this way. Well, we do MTM. MTM needs to be defined this way, and everybody pushes and pulls, and we need to add this word, add this component. Why not just have granular definitions across hundreds and hundreds and hundreds of different types of interventions? Because really, that's what's needed, right? What you need not is we murdered somebody. What you need is it was Professor Plum in the conservatory with a lead pipe. Okay, that's more helpful. Okay, it was Colonel Mustard with a candlestick in the library. That's what we're talking about here. It was a diabetes medication review with device education with initial assessment. Think of how much more valuable that is, not only to the person you're tapping on the shoulder in care coordination, but the payer. Oh, I did MTM. Well, what on earth does that mean? Well, let's define it, fight over the universal definition of it. No, let's just get to granular definitions and then send these codes so everybody knows here's what we did in a very granular way. Very, very important for our profession and our sector right now because nobody understands what we do. Recommend increased dose. So here's our action plan. All right. We did a diabetes medication review. We started the patient on MedSync. There's a MedSync code. Ding, 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 ding. Great, great, great thing to have that MedSync code, particularly if you're a health services researcher right now. Pharmacist administered pneumococcal vaccine. So these are all structured data with structured numbers that are behind it. Then we've got a little bit of free text. We've got a care coordination note. All right. So that should give you a sense of what it is. Why did we choose care planning? We had a couple different options. We landed on care planning. Consider this. Basically, half of all Americans suffer from at least one chronic disease. And you've got these, heart disease, cancer, stroke, chronic obstructive pulmonary disease, and diabetes are 2/3 of all deaths. Importantly, where we're at with health reform, payment reform, the national debt, and everything else is 75% of the nation's healthcare spending is on chronic disease. 75%. Even more stark for us that are in this business and know that public payers are critical in pharmacy, 96% of Medicare spending and 86% of medical spending is chronic disease. Let that sink in a little bit. All right, how do we treat chronic disease? How do we prevent below-the-knee amputations, blindness, kidney disease? Well, we got to treat diabetes. Those are the #1 leading causes, diabetes. How do we treat diabetes? Well, we can do diet and exercise. Well, that's a plan, by the way. But for the most part, it's meds. And the bugger of it is meds are the things that go with the patient when they're not in front of providers. And they bounce around to all sorts of different patients, right? So the way we operate in our healthcare system is, I can go from place to place to place, and they've got their particular role. But everybody touches meds. And so you need this ongoing dynamic process if you're actually going to optimize medication use. And so the PECP, the Pharmacist Electronic Care Plan, is modeled after that JCCP-endorsed pharmacist care process. I'm collecting, assessing, planning, and implementing it. It's always ongoing, living, breathing process. Having grown up with primary care and care management and thousands of care managers, I've lived and breathed the importance of there's no such thing as a static moment in time. You say, great, we're set. No, we started this, we stopped that, we took the lab. It's an ongoing living, breathing process. That's care planning. So for us in expressing the value in this sector, expressing the value whether you're a manufacturer, whether you're a pharmacist, whether you're in a health system or a pharmacy, or you're a care manager coordinating with a pharmacist doing med management, it really is this care planning process that helps the meds most realize their benefit. All right. So positioning the pharmacy sector for payment reform. I personally believe that the widespread adoption of the Pharmacist Electronic Care Plan, whether in its current form or however it gets modified over time or some version of it gets modified over time, this type of a thing is absolutely needed for us to engage in payment reform. Again, all those lines are breaking down between our relatively insulated silo in our different building with different people, and the rest of the healthcare system, the rest of financing, and the rest of payment. So we have to adopt something that allows us to adopt a service industry around medication optimization. So the rate limiting step right now to scalability of pharmacist services is lack of interoperable clinical data and payer interaction within workflow. And you've got basically two prevailing forces now that are squeezing and creating a bottleneck. You've got patients in need on the left, and there's no doubt that patients are in need. There's med baloney that goes on all day long, ill coordination. Oftentimes it's not intentional or it's not negligence. It's just a really, really complicated system with complicated patients and complicated circumstances, oftentimes treating themselves on the internet alone, et cetera, et cetera. And there's all this need because we know we're not getting, the $350 billion or $400 billion we're spending on medications in an outpatient way. We're not realizing a third, a fourth of the value of those medications to get to outcomes because of everything that's going on the left. You've got all these providers and interventionists on the right, except it's so expensive right now to administer these programs because we don't have standards. We don't have ubiquitous definitions. We don't have ubiquitous ways of communicating with each other, and so on and so forth. The other is that, and that makes it really expensive. So if you're going to get it to scale, if you're going to make it broad, if you're going to expand it to broader populations, you have to drive down the cost of administering these programs. For the pharmacist, going in my first early days, even in practicing, what I realized was I was spending 90% of my time gathering information, documenting, doing all this administrative stuff, and 10% of my time interacting with the patient and doing something about it and trying to figure out what needed to be done. We need to flip that. It needs to be less than 10% administrative and 90% I'm interacting with the patient and I'm doing something about this. I'm intervening, I'm following up, I'm coaching, and so on and so forth. So if we're going to open up those narrows, we've got to be able to standard to drive down the administrative cost to administer these if I'm a payer, a purchaser, a vendor, and we need to drive down the cost of the pharmacist so that if I get paid $100 and I spend $80 administering it, that's not going to work out because now I've only got $20 to pay the pharmacist. If I'm spending 95% of my time actually caring for the patient, 5% administering it, now I got something. Oops. All right, coming back here. So would a rose by any other name smell as sweet? And what that phrase means from Romeo and Juliet, for those of you that are would read such things, it's the names of things that do not affect what they really are, right? So everybody does MTM. My care managers at CNC do MTM. The pharmacists in the community do MTM. The call centers do MTM. The pharmacists in practices do MTM. Well, no, they do comprehensive med management. Okay, well, what does that mean? What's different? It's a mess because you can just say, a surgeon would never say, I do surgery, pay me for surgery. A primary care physician would say, I'm billing for primary care. What do you mean by that? Right? There's a granular description of here's the specific things that you in this setting did, what information you had available to you, how much time you spent. All of that is now built into Snomed Ct and the information to go with it to back it up. And the problem that this causes is that there are far more resources devoted to care management than MTM. We have to realize that in pharmacy world, okay? I often tell folks on the Medicaid program, depending on how you define care management, usually Medicaid programs, after federal and supplemental rebates, spend twice as much money on care management as they do on outpatient pharmacy. It's pretty remarkable. There are far more nurses and social workers out there doing a good job, by the way. I've seen it with their parts that they're good at, interacting with patients, how they're interacting with patients in their programs, than there are pharmacists out there doing these types of activities. In fact, probably third in line is pharmacy students and call centers out of schools of pharmacy. Pharmacists are actually down the list. So this is all going on out there, but there's no way to compare and contrast. There's no way to coordinate these activities. The most ill-coordinated people in our healthcare system right now are care coordinators, incidentally. There's no systematic way to differentiate or delineate. And then, of course, the data to measure program and quality is grossly inadequate. If you just have claims or you just have clinical or you just have patient reported, it's really the bringing of all those together to properly case mix adjust and so on and so forth. So if you're a payer on the phone or you interact with payers, I would encourage you to get into the standard. If you need help doing that, Shelley's always available at the HIT Collaborative, and it looks a little bit gnarly because it is a standard. But I think it's worth noting that there's so many opportunities here as a payer or purchaser to do some really innovative things and to get to a better handle on measurement and share information and start to build in some clinical measures as part of your payment models. So the example payer sheet, as part of our Innovations Award, we actually received, adjudicated, and sent payment for greater than 30,000 electronic care plans across more than 200 pharmacies. That information was used to coordinate care with care managers and primary care providers, as well as pretty extensive quality reporting, up to and including denying care plan payments because they didn't have the necessary information or they were of low quality. What information did we put on the payer sheet? Patient demographics, who authored it, encounter participant, location, type, reason, composition, custodian. Is that the practice, the pharmacy, the care manager? What's the detail? So basically, who did it? What was the setting of care? What was the plan coverage, medication list? What was the procedure, the communication? Was it referred? Who was it referred from? What was the patient goals detail? What were the outcomes? So again, it's not a unicorn. This is out there and it's being balloted. And personally, I think it's really important for it to be adopted. So I'm going to close up here, as promised, here in 4 minutes. Thanks to the Community Pharmacy Foundation for helping support putting up a website. So this is out there right now. You can go to it while you're on the webinar, www.eCarePlanInitiative.com. It's got background and history, what's the origin, the purpose, a more extensive version of what we're talking about today. You've got downloads and materials, so the actual specifications are there. They'll be updated regularly as it goes through balloting process and changes are being made. It's got actual software code, so there's these things called transforms. I need to go from FHIR to CCDA. There's probably not a lot of folks on the webinar that know what those specifically mean, but if you're in technology world, you do, and that helps you keep up to date. Updates on balloting, updates on implementations, who now is using it, where is it being used. If you've got questions or feedback, just email Shelley. She, in pharmacy world, she's our key person. There's a reason the Pharmacy HIT Collaborative exists. It's the pharmacy organizations getting together and the association saying, here's what we're doing all together. Just email her at shelley@pharmacyhit.org. Again, for the CPF grant, thanks to them, shout out. Really cool work going on here on development, care plan development, and workflow analysis. So again, workflow. There's super utilizer groups across all the vendors. So folks that have used this do a lot of care planning and have been submitting a lot of care plans. What is it that you're doing that you're able to do it successfully? How is it that you're going to counsel 20 patients? And it's no more than 20 or 30 seconds when you go back to the computer to say, here's the update to the care plan. They said they struggled with needles. Here's what we talked about. We're going to follow up next time they're in. That's a care plan. How do I get that in there? What are the best practices? Technical assistance. So a lot of vendors, I just got an email today from a group, a technology company that said, hey, we want to do this, and great. So I send them to the group that's providing technical assistance, and they will work with them to connect them. All different types of assistance, everything from they don't need a whole lot to they need a lot of extensive help, not a problem. Code development. Up there are the publicly available standards, but also the transforms. So Lantana was putting together transforms. Lots of people are putting together transforms. Again, what are those? That's something like, well, I send out a CCD from a hospital. It gets transformed into a Pharmacist Electronic Care Plan. Why is that important? Well, you can send it to a pharmacy. A pharmacy can consume it if they've got that standard. That's the other beauty of standards. You can have two different standards. And if you've got an apple and an orange, and you've got an apple and orange converter, now you don't even necessarily need to do some adoption if it's just some limited fields you need to share, and you collect both of those fields. So there's a lot in a continuity of care document that also exists in the pharmacist eCarePlan and vice versa. There's also transforms from one type of version of the standard to another, and so on and so forth. So those are publicly available and being created. They're on the website. And then testing, of course. So using the capabilities that ONC project came up with. So in that project it came up with, here's the test file, here's the test circumstances. If you can do these fields under these circumstances, congratulations, you're now electronic care plan capable. All you need to do is email Shelley for information on that and what's going on there as well. So where are the software vendors at, or the software solutions and technology companies? So all software solutions testing under the ONC project specification maintain all of the fields in blue on the left. So that's everybody has to do that to meet that ONC specification. In the future, so right now some software solutions are testing out and have in place all these fields. Not all of them have any or all of them in the green, but that's part of the evolution. But I just want to give you a sense of all the various rich information that's in the standard itself. So the standard's pretty vast, but you don't necessarily have to use all of it as well. So you can't boil the ocean on day one. So those that are on the left, if you go to the software solutions that are doing that on the left, here you've got that pharmacy management with embedded clinical documentation systems. So that's that embedded that we talked about on an earlier slide. If you go below that, there's clinical I've got that reversed, my apologies. Pharmacy management and integrated clinical documentation systems. So that would be Amplicare, Computer RX, RX30 McKesson. So I'll switch those as the deck goes out. Those are systems that are using a clinical documentation system and they are bolted on. So a good example of that, again, is like a Meditech EMR that's using Dr. First, or at least it was. They're fully embedded, fully integrated, and those are the lower left. The clinical documentation systems are the upper right. That's your DocSync, Pharmatica, Prescribe Wellness, and Strand. Those are of particular interest, of course, to the gig economy. I saw there was a company, kudos to David, the chairman of the PQA board, who's now looking into, hey, I'm a pharmacist out there, and I'm looking for somebody that needs help. Well, I need an EMR. Well, I need a clinical documentation system. I may not be dispensing meds, but I need a system. And then care management systems, Ecare, which is used by a major national chain, by the way, is a care management system that said, well, we actually are a care management system that wants to be able to serve pharmacists and pharmacies. And they adopted really quickly because clearly they have care planning. So that's what's in the marketplace now. I am 1 minute over. My apologies, Richard. Let me reintroduce Shelly Spiro. So she's been at nose to the grindstone in all of these meetings and pushing on this for quite a long time. And she can answer all sorts of detail about balloting and NCPDP work groups and HL7. She's on the front lines out there for us, on that wall, if you will, dealing with all of those specifics. We've just been the laboratory and trying to facilitate. So with that, Richard, do we have questions? And Shelly, do you have any closing thoughts?
Just I want to thank you, Troy, for a very comprehensive overview of this very complex document and a complex process and standard. I just appreciate all of the effort that the community pharmacy organizations have put towards really making this a reality. So we can come up with the concepts on the technology side and work with vendors to get them to follow standards, but it really takes a push from those who are on the ground using it to really make it work. So thank you for all of that, and thank you for a great presentation.
Well, great. Thank you, Troy. And thank you, Shelly, for joining to help answer questions. We do have a lot of questions from the audience, so we'll jump into those now. So the first question I have, in the Pharmacist eCare plan for interventions, will there be interventions related to the PQA medication therapy problems identified and subsequent resolution?
Shelly, do you want to kind of give a really short background of Snomed Ct and kind of how it covers the entire waterfront? So you can pick and choose as a payer, as a subset of pharmacy sector, which pieces and parts of those libraries that you use. Do you want to talk about the merge or the intersection between that and maybe what like the AMCP work group does?
Certainly. So we started out probably with identifying 50 Snomed Ct codes that pharmacists would use back well over 10 years ago. And we expanded it to over 600 clinical terms that we've identified and then put them into value sets or groups of codes that mean something, and we call that the framework of information. All of this is publicly available on the National Library of Medicine's Value Set Authority Center for your programmers who want to incorporate that. Very similar to what some of your compendiums do with your drug information within your systems. It is very comprehensive. We've looked at all of the drug therapy problems and potential drug therapy problems, made sure that we put that information out for public comment, work with payers and others who are working in MTM and even in the enhanced MTM program to make sure we capture all of that information. But it's growing because something new might come out, so we have a process for adding new terms that aren't currently identified today. As it fits in with the Pharmacy Quality Alliance, we're working closely with a group on that is identifying how to move towards Snomed Ct codes for medication therapy problems. And so all of that now, or the current medication therapy problems that are identified within the PQA standards, they can be mapped to Snomed today. And we're just looking to increase that and continue to increase that and work with PQA to create and make sure that we're capturing that information in a very codified way using the clinical terms that are identified within Snomed Ct.
So another way to think about this is the alphabet, okay? There's a certain number of letters in the alphabet. And if the alphabet's comprehensive, it can create all sorts of words for our language. So if I want to create table, I take T-A-B-L-E, and I put it together and I go, oh, that's a table. I know what a table is. Well, what did I take? I took that one component, T-A-B-L-N-E. So that's what your library is. And if I want to do lamp, L-A-M-P, right? So I'm picking 4 of those. If it's in it could just be an L, it could be an L and A, it could be an L and A and an M. So the answer is, because the selection of letters is so comprehensive at this point, yes, you can accommodate really kind of any setting, any kind of program, whether it's Part D MTM, whether it's comprehensive med management in the clinic, because what you're able to do then is mix and match those letters in order to create, this is what I did when I put those together. The alphabet's expanding a little bit, but for the most part, it's big enough where you can pick from them to create, okay, I know exactly what you did because we took this term, and this term, and these numbers. Richard, next question.
Okay, so if you had to pick whether it's embedded, bolted, or separate, which do you prefer or recommend for implementing this?
I steadfastly do not recommend. I can tell you with 100% sincerity, with every cell in my body, that different folks in different circumstances have different needs. I've seen businesses out there that use all 3 because they have different needs in different circumstances. The key, though, is that they're using it for all of the patients in those workflow circumstances, right? So I might have a workflow circumstance where I need and want the pharmacy management system. I might not, because I've got a clinical hub that serves 5 of my pharmacies, and I want to be able to have more of a bolted-on system or more set-apart system. I might be a 1099 consultant pharmacist within the ASCP crowd that says, I'm not dispensing meds, so I want this type of system, and it's my EMR. I might be a pharmacist in a practice that's trying to do CCM, and I might use a system that basically, yes, it's set aside. Maybe I got single sign-on, but I really need to operate over here because my electronic medical record doesn't really work. It's fitness for a different use. And so I don't think there's really an appropriate, this is the best way to go. It really depends on the pharmacist and the circumstance that they're in.
I totally agree, Troy. You're right on track, and that's the beauty of what we're doing. Is you as a pharmacist should pick the system that's going to work for you and your workflow to make you the most productive that you can be, especially for clinical documentation. And it's up to you to work with your system vendor to design a system that is going to maximize your productivity. And so we, from the standard standpoint, want to make sure you have all the tools and availability to do that. And behind the scenes, your system should be working to make information flow in a very interoperable way.
Okay. Is there any work being done to track patient populations who are being treated with the Pharmacy eCare Plan and their outcomes?
Yeah, certainly we do that within the CPSN networks, the Enhanced Services Pharmacy networks. It's a requirement. You can't participate in the network unless you're able to submit a care plan and submit to quality reporting. The data is really, it's very difficult to cheat a care plan. I can tell you that right now. You definitely know who's being naughty and who's being nice and who's really filling it out well. If you see care plans that don't change over time and they're doing MedSync, that's a pretty good indication that it's autofill, for instance. And so, yeah, certainly we do that. We're seeing more and more interest by manufacturers, by payers to say, hey, you know what, this is giving me the depth of information that I need in order to do quality assurance, but also get a handle on my population on data streams I don't have access to. I oftentimes have care managers if I'm an MCO I have providers and care managers. If I'm a health system, they're becoming payers now. So, it becomes sort of obvious as to why you would want to use this in all three facets: payment, care coordination, and quality assurance.
Yeah, I totally agree with what you're saying, Troy. And for the future, this is going to be the way our systems will capture information. The vision is you as a practitioner should be taking care of your patients. You should be doing everything that you have to do, and you need to utilize your system to pull out the information that's needed. What each payer or each person from a quality standpoint who wants to capture information, that information should flow freely out of the system no matter what system that you're using. That's our vision. Right now we're sort of at the interim that as adoption occurs and implementation occurs, each payer or person who wants information is going to give you that criteria. The idea is if we can get our pharmacists to clinically document in a very standard way, that information should be able to flow out of the system consistently in all practice settings.
I would also submit that there are, I think I got a shout out to Melissa McGivney at the University of Pittsburgh this morning. I think there's now 44 different schools of pharmacy interested in collaborating, and certainly they're very interested in this data, not only for teaching purposes, but also for all the sort of quality improvement and practice transformation efforts that are needed out there.
All right. Could you address the importance of the balloting process to the future growth and expansion of the eCare plan?
Yes, I'll take that one on.
Yes, please.
It's with any standards that we use today. Most pharmacists are familiar with the telecommunication for claims and for script, for e-prescribing. Those are standards that have been out there for a long time within pharmacy, and they have evolved. New versions come up because new criteria is needed. We want to put more into the standard. And that's a normal process within standards development. This is the same thing with the Pharmacist Electronic Care Plan. Where it's different is that it doesn't necessarily follow a traditional NCPDP standard, but follows more of what the rest of the medical community is doing in terms of defining how they standardize information. And so this is a harmonization of what we're doing with NCPDP with HL7, where most of the other portions of medical community are using towards that standard. All of the standards now, one of the requirements are they have to be backward compatible. And this helps with adoption and implementation. We have to be able to add new things because things change within healthcare, how we document, how we take care of our patients, new technology, new innovation, new clinical processes are always emerging, especially with pharmacogenomics and other areas of care that we're beginning to work on. And the standards have to be able to move with the innovations of the medical care that we're providing.
So another way of saying that is, I'm an apple, Shelley's an orange, Richard's a banana. If we all get together and say, well, we're going to ballot, which one are we going to choose? I say, well, I'd like for it to be an apple. Well, that's good for me. It might be a little tougher for the banana or the orange, but that's why the balloting process is there, and that's why it takes a little while, because there's lots of detail, but we all have to, we all have to agree on what those specifications are. So that's the critical nature of it. Interoperability only works if it's consensus driven.
I'll also say that on the balloting process, the balloting process isn't for your normal pharmacist. It's more for the programmers and system vendors who have to incorporate the standards or program those standards into the system that the clinician is using. And so the balloting process has been around for a very, very long time. And it just assures that everybody is, from a consensus standpoint, is on the same page. Everybody agrees that this is what they're going to use. And that's why it's important, but it's mostly for your system vendors and the programmers who are actually programming the technology to what you're using as a clinician.
Okay. Does the standard include specific directions for use as a part of the medication list?
I missed the first part of the question. Sorry, go ahead again.
Yeah, so does the standard include specific directions for use as a part of the medication list?
Yeah. Shelley, you want to take that?
Yes, it does. In the intervention section of the care plan, where a pharmacist is deciding, well, I'm going to intervene on these 3 medications, there's also a complete list of all the medications that we have access to. And the pharmacists in the system, depending on how they input that data, would have as much information, including the directions for use, indication, which physician prescribed it, which pharmacy filled it. There's quite a bit of information built in there. It's only as good as the information that's put into it, but the standard incorporates all of the information in relationship to the prescription.
Okay, can you comment on the usefulness of this technology in managed care? As was mentioned in the presentation, payers are now providers and vice versa.
Sure. 2 thoughts along those lines. Anecdotally, we were talking to some care management leads at a national name brand payer, Fortune 30 payer, and we said, so, when you're doing all these home visits, what are you finding? Well, about 90% of the issues that pop up in the home visits are med-related. Okay, well, what do you do with that? Well, that's just it. It's hard to do anything other than just coach the patient with what we can, because it's difficult to work with anybody else, communicate with anybody else, et cetera, et cetera. So all payers have provider supports, or they're providers themselves as far as infrastructure on the provision of care side, where it makes sense. On the payment for services side, again, I'll argue there's a lot more care management going on that is related to medications than there is dollars spent on medications themselves and efforts on medications themselves. And so not only on the sort of outpatient pharmacy side, but also on the care management structures and the quality structure side, now what I can do is, if I'm a director of pharmacy within an MCO, I can now say, hey, we're here to help actually work with that care manager that you're sending into the home as a pharmacy director. We're not just pharmacy claims, right? We can work to transcend programs. You're a part of the team. You're a part of the accountable care. You're a part of the payment reform. And I can see, we're bringing a little bit of the medical world over to us with this care planning, et cetera. The reverse can happen too. On the other side of the building are all sorts of folks struggling with all sorts of patient-centered medical home measures and care management measures and behavioral health measures that really have a lot to do with medications, right? So it's not just actually that you can adjudicate stuff with pharmacists or MTM or pharmacies. It's actually much, much more broad than that. I think particularly in the Medicaid MCO space, since the sponsors certainly in that space, the types of interventions that are required in the age blind and disabled population, the complex populations, are not flyby types of interventions. And so there's much, much more opportunity to put more intensive programs with data feedbacks that are needed so that you know what you're getting, but again, sharing that with the structures within your organization. I think again, payment reform and accountable care coming to pharmacy and pharmacy coming over to the medical side when it comes to that whole payment reform experience and accountable care is critical for all of us. And I think specifically the pharmacy groups within plans, and particularly Medicaid MCOs.
Yeah, I think that if you look at it this way from a managed care organization, especially from a technology standpoint, most of them have developed intrasystems to communicate care coordination. So the care plan is just a tool. It's a tool to standardize that information so it could be shared outside of any MCO type of system. And that's the key to this. It's a tool that is useful in all practice settings, but it is really meant especially for things like the VA, where their providers aren't necessarily connected to that particular VA system. They would have the means to share that information outside their systems. So many of the managed care organizations have built stuff intrasystem, and this is to really help share information outside of their system.
But you can certainly, we're about 5 programs in ourselves now where it's eCarePlan, no eCarePlan, no payment. And I'm pretty confident, I've put my reputation on the notion that this is really good for payment adjudication. because that pair sheet's in there. Certainly it'll get to different, it's on version 1.1 or whatever now. It'll be on 6 point whatever a couple years, or down the road it'll be more elegant and meet your needs more. But it's crystal clear to me, as somebody that's been both on the practice side, as I still practice, who's been on the program implementation side, the care management side, the primary care side, but also on the payer side, not only through grants, but also, on behalf of the state of North Carolina, that information coming in is super, super valuable to know what's going on out there and what I'm paying for and if I'm getting outcomes.
Okay, well, we're at the top of the hour. I'm going to ask one last question. What is the biggest lesson that has been learned through this pilot, and what is next in scaling this model and increasing its adoption?
I'll go first, Shelley. I'll let you close out. The biggest challenge for software solutions we observed was not actually meeting the transaction. It was actually having places in their systems to do the care planning, the intervention, the collection of the information. So drug therapy problems. Well, the hard part isn't saying, oh, I need to take that drug therapy problem from that pick list and put it in field 26 and send it in JSON or using RESTful API or stuff that's really standard in technology world now. That's not the hard part. The hard part is, well, I guess we need to put drug therapy problem pick list in our system, right? And that was the aha moment for me, that part of the really important part of everybody getting behind the standard is not just for the standard's sake and for the liquidity of the data for the reasons we talked about today, but is that it really pushes the industry to actually take drug therapy problems seriously and have it in their systems, to take laboratory results and say, yeah, the next barrier when we implement point-of-care testing in a pharmacy shouldn't be there's no place to put it in my system, right? And so that's the other really important reason of having this standard, is it pushes everybody along in making sure that they actually have these capabilities in their native systems of records, whatever type of pharmacist you are, wherever you're at.
Yeah, I totally agree with you, Troy. And I think that that from a technology standpoint, developing the standard was probably a lot easier than implementation and adoption. And that's where we're at. And that's with any type of technology, whether it's from a phone, moving from a flip phone to a smartphone to anything else that you're doing. It just takes time, and it takes awareness to actually move it in. The standard, the basis of the terminology, such as Snomed Ct, all of that is in place as a base to now help pharmacists clinically document in a very standard way within their system, so that we can then allow the system to pull the information out. Probably one of the best analogies we have is years ago, and I was one of these pharmacists who actually created a claim. Sometimes we had to write it out on a piece of paper and send one claim to one payer, another claim to another payer, or another one to a third payer. And we just, until we came up with the universal claim form, there wasn't a way to standardize that. Now, we all were doing things within our own pharmacy systems. We were developing workflows. Some workflow is better than others. Now everything has been able to standardize, so we increase our productivity with workflow. It's the same thing with clinical documentation. We need to, like Troy said, workflow. We now need to begin to work on the workflow to standardize how pharmacists are clinically documenting this information. The care plan is just a tool to help that standardization and to pull that in, to be able to share that information with others outside of your system.
All right. Well, thank you, Shelley, and thank you, Troy, for a very information-rich, informative presentation. I can tell you from the comments and questions we received, there's a lot of enthusiasm for the plan, and people are really excited about the progress that's been made over the last 1 to 2 years. So thank you again for speaking with us today. Thanks again to PerformerX for sponsoring today. And we hope everyone will stay in touch with PQA through social media and our website. And please take the survey at the end of this webinar. So thank you again for joining us today. Goodbye.